Good afternoon, and welcome to this Hospice News webinar sponsored by Advanced Hospice Management. Today we'll be talking about hospice revenue cycle management as we move towards 2021. We'll be exploring the pressures and challenges that impact RCM, including, of course, the COVID-19 pandemic and the Medicare Advantage hospice carve-in, among others. We have three presenters with us today. We have Delaine Henry, CEO of Advanced Hospice Management, who has 20 years of experience in hospice and home health billing and revenue cycle management. Delaine supports the AHM team of expert hospice billers across the country as they serve clients across the US and Puerto Rico. Focused on efficient, accurate billing and prompt collections, their goal is to get hospices paid in a predictable cycle that allows agencies to thrive while accompanying the goal of serving their community. Also, Aaron Blackmore, founder of Blackmore CPA. He founded the firm in 2016 with the aim of ensuring hospice leaders receive accurate, timely, and relevant financial reports. Their team has collectively closed thousands of hospice, palliative care, and home health agency month ends in all flavors of size, program makeup, and EMR configurations. Aaron has held numerous CFO positions throughout the country for hospices, ranging from 50 to 500 average daily census. His combined background of IT and accounting give him and his team a unique focus in the world of accounting firms. Also with us is Jen Keel, who has more than 20 years of operational and clinical leadership and consulting experience. She's currently the Chief Operating Officer for All Caring Hospice and Alliance Hospice and Palliative Care. Jen has a unique combination of operational, financial, and clinical experience from both agency and consulting perspectives. I want to thank each of our panelists for being here. Following their presentations, we'll hold a question and answer session. Listeners can submit questions by typing them into the designated box in the GoToWebinar app. Slides and a recording of the program will be sent to participants after the webinar. And without further delay, I'll hand it over to our presenters.
Thank you so much. This is Delaine Henry, CEO of Advanced Hospice Management, and I think we'll jump right in. So how are you guys going to present the slides? I apologize, Jim. So we'll discuss the RCM impact that we've experienced from the pandemic and COVID-19. Jen, would you like to kick us off?
Sure. I think probably we've seen some pretty intense impacts from the pandemic and from COVID-19 across the board, and RCM in particular. Probably the first area we've been impacted is with census. For our company, we're multi-site, so it's been location specific, but our general trend during the coronavirus pandemic has been an increase in admissions, but we're not seeing the accompanying increase in census, because what we're seeing is a real drop in length of stay. And what that means to us for our revenue cycle is that we're doing a tremendous amount of front work with getting signatures and managing documentation, insurance verification, blah, 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 for the same amount of revenue, because we're not billing more days. We're billing the same number of days. We're just billing more beneficiaries. And so our upfront work has become burdensome. We're also seeing a slowdown in our cycle due to the constraints of the pandemic, specifically in the late spring and early in the summer, being able to get a hold of physicians and get a hold of insurance companies and actually manage the workload that we needed to manage to keep our work going as quickly as we would like to. On the back end, we're not seeing a delay in payment, but it seems to be what I would call churn and burn. We're working very, very hard, almost twice as hard as we were working prior to the pandemic for the same amount of revenue. So it certainly impacted our billing process in that respect on the front end.
So it's more a gathering of your clinical documentation, getting your authorization signature signed, all of the front end paperwork you have to do for every admission, but your length of stay is so low that you're not, the revenue is not a result of the admission.
Absolutely.
And I can say from our end, what we see, of course, we as the billing team are on the end of the process for admissions and care, and then ultimately billing and collecting revenue. So we see a lot of the same things, and I think we don't directly see the clinical impact, but what we did see was the challenge of the CARES Act and how it could be applied, where hospices were unable to see patients in facilities, and there were a lot of questions about whether those dates of service were billable. So they spent a lot of time reviewing and asking questions and seeking help from consultants to try to determine what was billable and what was not. And I do believe a lot of agencies chose not to bill claims that maybe were billable, but were erring on the side of caution because of the threat of audits and takebacks and things like that. They were uncomfortable billing out without visits, without reassessments and things like that. And also we saw a lot of patients where the families were afraid of the nurses going in, so they were discharging from hospice because they were afraid of exposure, so there were a lot of censuses that dropped. But on the revenue side, I think for us, I think it was a huge adjustment for a lot of agencies who obviously operate in a brick and mortar building, and it was difficult to send their staff home to work and to try to keep a cohesive team and a cohesive process for all of those items that you mentioned. So the pre-bill team, who manages documentation and makes sure all of the requirements are met before billing, had a difficult time adjusting to doing that remotely, as opposed to doing it in weekly team meetings or weekly clinical meetings. And so the revenue cycle itself slowed way down.
Absolutely. And we did not send our business office front end team to work remotely for that reason. Another component of that a lot of people I don't know factored into this is the constraints of HIPAA and actually workers' compensation. When you have people working out of their home and their children and their husband are sitting there and they're talking about sensitive patient information and they're receiving information that's confidential. So we actually kept our business office staff in-house in a very safe environment, and our clinical field staff works remotely for the most part anyway. We're lucky because we have big enough buildings and small enough staff that we could pull that off. We still found facilities wouldn't let us in. As you said, fears about billing because of were we able to get in? They weren't letting us in. We were doing a lot more telehealth and spent a lot of time investigating if we could actually bill for the telehealth visits. Were we meeting the conditions of participation, given the waivers that were in place? And a big component of the pandemic for me from day one has been staying up to date on all the different waivers that are coming out and all the regulatory changes, along with all the policy changes that have to go into place in order to meet those regulatory requirements, because you can't simply implement telehealth if you don't have a telehealth policy. So that was another really fun and enjoyable impact that we've been going through for the last 8 or 9 months now.
Right, exactly. Aaron, do you have anything to add?
Yeah, absolutely. So just in terms of impacts that we have seen, so I am Aaron Blackmore again. We work in the back office of hospices throughout the country, not directly on site unless requested. So similar to Delaine's structure. And we went down our list of clients, kind of looking at grouping them by size, ADC, geography, and exactly, Jen, what you were saying just a second ago, the nursing home and facility mix impacts were the biggest impacts, and then some of our clients had to shut down inpatient operations altogether. So some of them had situations where they rent a wing of a hospital, or where they have privileges, and then those privileges came into question or became a burden for the facility or for the other provider, and then that no longer was a viable option. So, and one of the reasons we have to assess that across the board is because we are looking at the sort of CARES Act, the HHS fund impacts to revenue stipulation that's in that that particular act that was passed. So yes, in terms of immediate impacts from the pandemic, we saw inpatient units were the biggest areas where we had to had clients go from a profitable inpatient unit. In some instances, this was the first fiscal year of profitable inpatient operations after the rate adjustments last October, and then suddenly to go from that to a pretty big loss center on the financials was a tough pill for many of our agencies to swallow, especially smaller ones. And that's what we also saw, was that smaller agencies had more, to us, we seem to see more impact in the kind of when we grouped them in the under 100 ADC group, that their impacts were more severe in terms of overall ADC, because they were seeing the shorter lengths of stay, seeing a lot more same day, or as I like to call it, a lot more move of brink of death care, where just the whole care term lasts 7 days or less. That's one of the metrics we like to look at, is percentage of patients that live 7 days or less. And many of our clients were pushing towards 50%, which is an unusually high number in this period of time. And that happens when the referral community holds on to their patients longer. Then aside from just revenue impacts, though, as you were saying, with the salaries, yeah, our payroll dollars relative to ADC have been up across the board. I mean, so many shifts and so many people were paid for work and for time that wasn't actually productive field time. So you have people who shifted to working from home where they could, if they were in, let's say, an administrative capacity, and other folks that had to be home for various reasons, personal reasons. So we had a lot of hospices have tremendous payroll dollars that were for non-working personnel, essentially. So yes, we had we saw a lot of really bleeding out red ink kinds of financials for that second quarter, when we saw a lot of payroll increases to payroll dollars, and not an offset to revenue to speak of, apart from our presentation of kind of how we were tracking just the supplemental funding that was coming out of the SBA for that. So that's one of the reasons we were trying to preserve, or trying to present the payroll impacts and separately the payroll offsets from PPP, because from just a holistic, how do we measure our businesses financially, this has presented a challenge because of the non-recurring, kind of non-routine issues around COVID. And then of course, yeah, just the more expensive, as I call it, brink of death model of care, whereas hospice was designed to be on average a longer overall length of stay. And when that average length of stay becomes 7 days or less for many of your new admissions, you start to see the financial picture, how quickly it can go from a sustainable reimbursement model to a completely unsustainable model, almost entirely depending on the length of stay of your current admissions group.
Sure. So if we could go to the next slide, Aaron, I'll just pose this question to you. Do you feel like we are any better positioned going into the fall? And, just watching the news, and the numbers are trending up, and what they're saying is we will again see a rise. Do we feel like we're in a better position to function through another peak in COVID cases?
I do think agencies are more responsive with respect to the expectations around what a pandemic work-life balance looks like. And I guess everyone's first concern right now, this is a little bit, again, I keep bringing up PPP and CARES, and it's because most of our clients, when it comes to questions, out of all the questions that we get, 19 of them are going to be about their money. And then maybe every now and then we get one that's about something like carve-in or something else. So everybody right now is asking me, when are we going to know if we can keep our money? And I only bring that up because, yeah, that is an important consideration that everyone's asking right now, but long term, it's not really a strategic question. It's just a tactical question of whether or not the applications are when the deadlines are and when they're going to be evaluating those funds. But long term, my concerns are around the facilities and the hospitals and these sort of non-home hospice settings, and then concerns around, we don't get too many questions that are clinically related, obviously being an accounting firm, but I do hear a lot on the grapevine just as far as the telehealth model, what will hospices be allowed to do, and and in CMS as well, responding to face-to-faces, and what can be done telehealth versus what has to be done face-to-face in these kinds of situations. So hopefully there will be a more clear model laid out for what is and isn't allowed. And then longer term, I mean, healthcare, I think overall healthcare delivery capacity is a big one, and of course, just the whole hospice reimbursement methodology. Could we could there be sort of variable pieces or components of it for times like these when there's a peak issues in healthcare that allow providers to apply for more reimbursement? I mean, I know they did the CARES distribution, but it was really just kind of a knee jerk. To me, felt like just a, here's some money, we're just going to kind of dump it into the system. But will we see more of a requirement going forward in healthcare to plan around peak or sort of black swan events like this, emergency preparedness, basically, that like you have in other critical sectors like defense and telecommunications, and healthcare is certainly one that has that built into it at the hospital level. But I think we might see more hospices have to participate in those kinds of emergency plan meetings and discussions as well. So, but overall, I mean, financial impacts long term, that's still kind of a big unknown, to us, because I mean, we're trying to discuss that kind of thing with, I mean, what we're gonna see with our clients, but most of them have not had serious census impacts. We're just talking about trying to get units either back opening up, or we've had some who were renting have to start planning either a capital build out for an inpatient unit setting because that's a service that they offered before that now they can't, things like that. So I feel like we're having a lot of sort of immediate concerns that are sort of drowning out the longer term, as is often the case when there's kind of an immediate fire that needs to be put out. What are we going to do 3 years from now sort of gets tabled for later.
Sure. Yeah, absolutely. So on our end, from a billing perspective going forward, I think that agencies who have kind of gotten over the hump with the issues we spoke about initially, work at home and the team being separated when they're usually together. And I know Jen said her team stayed in-house, but a lot of agencies don't have that option, whether it's because of their geographic location, or some are actually the hospice office is located within a facility like you're talking about, Aaron. So they own maybe a nursing home and they have a GIP wing, and their hospice is actually in the facility. And with the COVID rules, those non-essential people were not allowed in, so they were forced to work at home. And a lot of the issues we saw initially were some had just basic, EMR issues and connectivity issues, and were really not schooled in using the web-based programs like Zoom or WebEx, and had to really adjust to those types of meetings. And I think that now they're really putting a lot of training effort into making sure their IT works correctly. They all have access to every portal and EMR and everything that they need to be able to work successfully from home. And they're also working on the challenges of work at home, like, that a lot of people still have children homeschooling. And so it is a difficult environment to adjust to when you have multiple people in the home. I mean, I know a lot of couples who both husband and wife are working from home along with homeschooling their kids. So that has been a challenge. And what we're seeing financially as the impact, of course, is just a slowdown in all of the processes. Some of the same things that Jen mentioned earlier, getting signatures, and some of the payers still send a paper check with a paper remit, and so someone has to retrieve that, whether it's from the PO box or from the office itself, and then scan it up, send it over. There's just a lot of loose ends that I am hoping that everyone is starting to tie up so that the virtual work world becomes smoother, and as a result, that the revenue cycle becomes smoother. So we're helping in every way that we can to make sure our clients have the correct access, the knowledge to use what they need, and if there's a way we can assist, we certainly do. Jen, what are you guys doing looking forward?
Honestly, I'm also a nurse, so I have a kind of a clinical perspective on this. And very early out of the gate for us, one of my locations, I had a run of COVID through my entire staff, which, something none of us have actually talked about, but the staffing implications when you have 50% of your staff out for 21 days and they're really sick. There's that whole other component of this from a revenue and cost perspective and staffing, and looking into the winter months. They're calling it COVID flu. The concept that, we're entering flu season right now. If you haven't got your flu shot yet, my plug, get it done. But I'm anticipating a repeat of what we went through early spring in terms of numbers and restrictions. Having to work from home more, the lack of access to our patients and these ongoing lockdowns, our case mix shift, I didn't mention earlier, we were basically 60-40 facility versus home, and we are now running 80-20 home versus facility. I anticipate we're going to continue this churn and burn. We're going to continue to struggle with staffing. There is, Aaron talked about the payroll related to ADC. There's also this competitive payroll concept where, there are markets that we are in where hospitals and facilities are paying hazard pay that are in amounts that we cannot be competitive with. And it is a challenge to keep and retain and recruit good staff, but in particular that frontline caregiver, the hospice aide. It is very hard to find people who are willing to take the risk of going out and caring for patients for the amount that hospice aides traditionally make. So the actual market itself, wage base has increased tremendously. So we're essentially looking at, patients who are in the first 7 days of care, which we know are the most expensive, versus the last 7 days of care, which are also the most expensive. So they're mostly in the most expensive care providing time that there is. And on top of that, we're paying more to staff and cover. There's a lot of risk, and we don't see, more CARES or PPP funding on the horizon to help supplement at increased cost. So, the cost of doing business is way up, and there's very little ROI to accompany that. So, just looking at process and, FEMA talks about emergency operations planning, which as hospices were required to do. They talk about this as the new normal. When you come through a pandemic or a crisis, you settle into a place where you return not necessarily to your original baseline, but to a new baseline. And I anticipate this is how things are going to be probably through the end of 2021, beginning of 2022, which is a little bit daunting.
Sure. Absolutely. So I think we can move on to the next topic. What are the permanent remote workforce impacts of COVID? So for us as a remote team, we are built on a platform. Advanced Hospice Management is built on a platform of a work-at-home workforce. So this has always been how we've operated. So for us, it is business as usual. We have a biller assigned to every account with a backup team. So should someone get sick, which we have been extremely fortunate to not have any of our staff come down with COVID, and that has been a tremendous help. But when you consider that we don't work face-to-face with each other, we are not at risk of sharing that virus with each other. But if someone were to come down with COVID, we have multiple people to take up their accounts, manage their accounts while they're getting better. So there's never a disruption in service to the client. I think the number one issue that we see, or the number one challenge we see for the clients themselves, is hiring and training. it's really difficult to hire and train someone in the billing department, whether it is a biller or someone who manages the pre-bill process and makes sure that all the requirements are met before claims go out the door, someone in intake and authorizations who manages referrals. You know, those positions are difficult to train remotely, especially if it's never been done and there's not a clear platform, a workflow, and training and oversight built for that particular position. So, you know, for us, that's how we do it every day. I mean, if we hire someone new and add to our team, we have a fully built process for training and oversight, and it works very well. I think that in-house training is going to be one of the major challenges facing a lot of hospices across the country, particularly going into, like Jen said, another peak of COVID, you know, where you may have staff exposed or ill and you're scrambling to find someone to cover. I think those are going to be real concerns and things that need to be addressed. And of course, you know, one of the possibilities for a solution, and I think it's a great one, is partnering with us to be a backup situation where if you have someone out sick and you know, it happens from one day to the next, then you have someone to step in and manage your revenue cycle immediately without disruption. Jen, what do you think is your impact?
So probably the hard part about hospice, and this is kind of a nursing clinical thing again, you know, this is end of life. We have one chance to do this right. So from a clinical perspective, is remote telehealth care even an effective means of delivering health care in the hospice environment? And I have my own personal opinion on that, but I don't know that I think a social worker sitting on the other end of an Apple telephone is giving the same connected care that we give when we're in person. So navigating how to get in front of patients, but to your point, the billing and the financial management and the paperwork, kind of the back of house stuff, for us, we are incapacitated if we lose business office people, whether it's the intake manager or the front of house business office manager. For us, when those people aren't able to work, it virtually shuts down our ability to get our billing together, even, you know, our pre-bill team, as you called it. So that automatically falls to somebody else in the office, and oftentimes that person's a clinical manager or an executive manager who are already trying to source PPE and things like that. So for us, the goal is to try to recruit almost a backup team, and, you know, utilizing your services, having somebody on the back end of billing who stays on top of things and keeps us focused when we're all over the place. I know that probably sounds strange, but when every single day you walk into a different crisis and it's one that you've never ever managed before, because this is very new still, it's really easy to lose sight of things, especially like aging. You know, you forget about those things. They're not on the front of your mind, and having somebody on the back end of billing who's got their finger on the pulse, who's not getting interruptions. That's one thing I will say, you know, consistency from our billing company, no interruptions. It's been a seamless process, which gives me one less thing that I lose sleep over.
Well, great. We're glad to hear that. And Aaron, I'm sure that all of those things we've mentioned, all of the challenges in-house and then billing, you know, delays because of the in-house challenges affect the accounting and reporting.
So absolutely. I mean, just right off the bat, you know, COVID, when it sort of came into the to the purview here, it stress tested our business model, as it did many. But like you, Delaine, we're a 100% remote service provider in this space. We've often worked closely with clients that want us to, or hospices have had us come on site quite often, and we have done a lot of consulting in the past that has involved a lot of travel. But our business model effectively changed overnight to a new paradigm. And instead of having a lot of sort of one-off consult types of work, and then the rest of our firm structure was just to provide, accounting, to provide an accounting service for our clients. But then when COVID hit, we realized, we manage a lot of month-end financials, and we've always done this work from home thing. And our hospice clients, especially the ones that that have still some of their finance team on premise, and then we work with them. We've become much more of a whole finance manager, what I'd call, I guess, like an in-house CFO, because most of our hospices, don't have an in-house CFO, because they're just not quite at the size where that makes a good, a good financial case. But then once you have something like this happen, they realize that the oversight wasn't there, and that's what we're accustomed to doing. So we've sort of changed our whole business model to manage and provide not just an expected outcome of the month-end close and financials, but to actually manage their whole back office team. So we're running a lot more meetings now, running board, not running board meetings, but providing structures. And a lot of our hospices have started, switched to using kind of our Teams and our Zoom and some of our accounts for all of their meetings. That started happening kind of right away, but I quickly saw as the pandemic was going on that we started, we saw the same thing. So just like our hospices felt like they had more payroll and more more work and less time, and we had the exact same thing happen. We started immediately having to step up the amount of oversight that we were providing of the actual hospice personnel. So now
Sure.
that's the main thing that has changed. We always worked from home, but we're managing twice as many folks, because we're managing a lot more hospice personnel now, and then that starts to segue into all of the across kind of co-managing those other areas of responsibility that tie into the finance department, like payroll, which is more of an HR function, and then development areas, which have a component that is also financial reporting, and ties into the GL. So there are areas where now we're having to manage more departments and more people than we've ever had to manage before, when we were just previously engaged as as an outside accounting member of their accounting team. So now we've sort of stepped into more of what feels like a management role with our agencies versus a transactional role to get done on the month end and on the financials. And then just from the standpoint of my team, that's what we had to do right away, was get a plan in place to start hiring. So we put a plan into place at March when this started to happen, from April through actually September, to hire a person a month. And for us, that was a pretty quick, having to go out and just start doing a lot of hiring and recruiting. So that also was a big shift that ate up a lot of our focus and attention, was to put an immediate personnel plan into place to double our personnel. Because after COVID, that's what happened to us, at least, was our phones were ringing off the hook around the clock. And so for the first time too, instead of just adding, we've added clients at a pretty predictable rate. Now we're in a position where we are forced to waitlist these kinds of engagements, because we're so heavily involved in an onboarding stage, because we come in and assess every system, EMR and donor and payroll, and reconfigure all of these systems so that they'll talk to one another. And that's a tremendous amount of work on the front end of an accounting engagement. So that has shifted our work as well, to have to structure and plan things way out in advance, much more so than we ever did previously. So I would say, from both of how we work remotely, our workload expectations, which have gone up tremendously, are, certainly our rates and our tiers have gone up. The amount that we're doing is more than double what we were, what we're charging. So we aren't, when I say that, we're managing a lot more people, and that just eats up a lot more time, of course. But it's that's where we found our hospices have really needed us in this time, because we already knew how to manage and work remotely. It just made sense for our team to then start to meet weekly and with certain staff members and structure these kinds of meetings and deadlines. And we put outlines or timelines into place for all of our clients, and all their team members and everything that rolls into the finance department. Whereas before, I'd say it was just a little bit more, a little more loosey-goosey. And now we're having to go in and really manage a lot of clients' personnel's schedules. And, we need to know their time off. We need to plan around kind of all these, if we need to sub in and run their payroll for them, or what are we're kind of picking up everything from like whatever the loose ends are that they're not getting done for one reason or another, like a payroll person who gets COVID or has a family member with COVID. Well, now all of a sudden we're payroll. But like you said, Delaine, that's where, in addition to what we do for them every month, they value that they can give us a call, because otherwise that those kinds of functions, they don't know how to, or it's difficult to pivot if you've got somebody that's suddenly out who's in a key position like payroll and you have no backup plan. So we are, the backup plan / cross training on top of just the financial reporting month-end close for most of our clients. And so that kind of emergency plan, call Blackmore, kind of part of the emergency team. Yeah.
And that's amazing that you guys were able to accommodate those clients that quickly, because I do believe a lot of agencies face those exact issues like we talked about. Someone's out sick or someone's out caring for a family member, and they're a lot of smaller agencies and even medium-sized agencies just don't have the capacity to have a backup team for those types of duties. Payroll is not, usually something that is handled by multiple people in a small agency. So right. I think that's a fantastic backup option for your clients.
Right. And that's the beauty of, with our clients, we felt like we were in a place where we could jump in and help them out. Whereas we had many come to us during, right after COVID, hey, can you jump in? And it's like, well, payroll and, just like you, but Delaine, billing. I mean, these are not things you can flip a switch and just do the next day. It takes a tremendous amount of time in the onboarding and kind of getting up to speed processes. So our hospices that we worked with, that we already had those relationships with, we were able to jump in and, and be that for them and jump into a much more involved role than we would have been able to otherwise. And meanwhile, we're also onboarding, around the clock, like all these, like crazy, all the new hospice interests. So that's the other piece that we've seen, is just all of a sudden, it's like overnight, the interest in remote services. And I think because this is an area that has long been viewed as an area that hospices want to keep in their control. But I think there's an openness and maybe even more of an understanding of the ROI and of the value to having off-site partnerships in these sort of strategic areas. It's not just a cost savings center. It's an ROI as well as an emergency plan.
Absolutely. So I think we can go to the next topic, which is probably of big interest to a lot of our attendees, which is the Medicare Advantage carve-in for 2021 and how we see it impacting our clients. And, from the billing perspective, of course, this led me to about 50 questions immediately as just in how we will implement what Medicare has laid out for us as the process for billing these pilot programs. So for those of you who may not have read everything that has been published by Medicare for the Hospice Pilot Advantage program, they released an MLN Matters, NM 11754, and that release outlined how Medicare says we have to bill hospice claims to Medicare and to the Medicare Advantage plan simultaneously. And I say simultaneously because the claims will go to both payers as primary. And they also still require us to bill or to file a notice of election with Medicare, and it has to be timely within 5 days, just like for a Medicare patient. So it's a challenge in a couple of ways, and I think it is a billing challenge, but for the most part, I think the first challenge we must tackle is the EMR challenge. So some EMRs, some of the hospice softwares will allow for a primary payer, a secondary payer, and you can flip those back and forth. So claim production to Medicare and then turning around and submitting the same claim to another payer, but not in a secondary payer format, is an option. You can do that. There's functionality for it. But there are several EMRs that we use that don't have functionality for that. So it becomes a billing, collections, revenue cycle, and accounting challenge, because if you're billing out to Medicare, which we have to do first, and then you turn around and bill to the managed care plan in another way, whether not through your software, maybe you do it through the clearinghouse or on paper or however you do that, but you receive payment back from the Advantage plan as opposed to from Medicare, then you have to post that payment. And if you're posting it to a patient in Medicare in your system, then you're technically not posting that money to the right payer. So we've seen some technical challenges in this process. And of course, I think for agencies that are in areas, and not all states are participating, if you haven't seen the map, if you don't have the list, we will make sure that list goes out after this call to all of our attendees. But for some states, and I believe Illinois and Ohio, Jen, you can help me out there. Illinois is a covered state, has some plans that are participating, correct? And those, so how are agencies going to manage these plans? How do you know what your impact will be revenue-wise? And one of the first things that I think is when we have a new payer in hospice, and I think this will be very similar to what happened in home health, when home health started billing to the managed care plans, there was a lot of confusion by the plans. They didn't know how to process a home health claim. I foresee that same issue. I'm not sure that the plans will know what to do with a hospice claim. You know, it is a unique claim. It's got unique information on it, and I just don't know if they'll be ready. So I think there may be a revenue delay. Medicare has instructed the managed care plans have to pay hospice providers at the Medicare rates for all services, whether you are contracted or not contracted, in-network or out-of-network. So that all sounds really plain and clear, and that's how it should go. But my concern is just the actual processing time. What will they do with your claim when they receive it? How long will it take them to pay it? And you know that Medicare is such a predictable payer, and it's a 14-day turnaround on your claim, so it makes your budgeting and projections and everything very predictable. And so for agencies who are in areas that have participating plans in this pilot, I think it's really important for everyone to know how big of an impact that will have on your agency. And there are a few things you can do to help determine that. So keep in mind that the pilot programs go into effect for admissions on or after January 1. So if you have patients right now who have plans on their Medicare Common Working File eligibility, and those plans are participating plans, they really don't impact those patients who are on service now. But if the patient discharges and readmits, it's important to make sure you look at that eligibility again and don't just assume that they're Medicare. They may have a plan. But what your current census can tell you is how many patients do you have? If this went into effect today and it did impact your current census, how many patients do you have with participating plans? That will give you an idea of how much Medicare revenue might be deferred after the first of the year on admissions. This is only on admissions, but it gives you some idea, helps you to start to quantify what that impact in your revenue might be. And so for me, that would be the first place to start, to kind of look at what you can expect on admissions after 1/1. And then, of course, as I mentioned, the EMR capabilities for billing to primary insurances. And Medicare's instruction is we file a notice of election with Medicare, we file the claim to Medicare, and then it will kick back to us with a certain language that says, you know, this patient's covered under a plan that's participating in the pilot, and then at that point you submit the claim to the MA plan. So it will happen quickly, and I don't think anybody wants to be in their EMR flipping primary payers around every month and trying to manage it that way. I'm hoping that there will be some added capacity to the EMRs that don't currently have that capability, so that we will be able to bill them simultaneously, and then, of course, or transfer balances without it being a secondary payer situation. And then I think the other piece that agencies should be aware of or actually implement is, conversation with your CPA or your finance team, or if you're a Blackmore client, you want to discuss how posting payments and any of those challenges with basically creating two claims for the same dates of service might impact your revenue reports and your payment reports and things like that. So I think that's definitely where I would start to manage, what your expectations can be of these MA plans. And then just a side note, I actually found the proposal that Medicare put out when they were calling for plans who wanted to participate. So it was like an application process. And reading through that was pretty interesting, because while Medicare says in the publication that providers do not have to be contracted, they do not have to be a network, but yet the payers have to pay them, there's some language in there in the call for participating plans about in-network providers, and that payers will have an opportunity to consult with their patients and give them a list of in-network providers and things like that. So I do feel like getting contracted with these MA plans would be to the advantage of the agencies, and doing it early prevents them from closing their opportunity to get contracted. I know some payers will say that they have enough of a particular type of provider, so they will not accept new contracts. And I think as this program goes on, maybe not in 2021, but in 2022, I think it'll get a little more competitive for contracts. But I want to point out that in your language in your contract, you always want to make sure that you can have some kind of language that states that they pay you at the current Medicare rate for the dates of service, so that you're not locked into a dollar rate. And as Medicare rates may go up, your contract may be stuck in some old rates, and you're not getting all of your dollars. So that's my spiel on the Medicare Advantage plan. Jen, I don't know if you guys are doing any prep work or anything you have to add.
I would say that the thing that I'm most painfully aware of with this is that, once again, as with how COVID hit smaller companies, if you're a big national corporate organization, you have a contracting team. If you're a small hospice that's trying to struggle through the challenges of coronavirus, contracting with a value-based insurance design program is challenging, because you have to bring KPIs and metrics to the table when you're starting to have those conversations. And while Medicare has been very clear that these payer sources will pay in and out of network 2021, 2022, come 2023, there's a lot of question about what that reimbursement's going to look like and what's going to happen to out-of-network providers who aren't contracted. And those payment details are really still very vague and may not incentivize these Medicare Advantage plans to enroll patients in hospice because of the money. And the thing that you touched on, I have to say that my biggest concern is that working with non-Medicare payer sources really, really lengthens your revenue cycle, because they kick claims back for the stupidest reasons. And now we're going to have to file and then file again. And that's going to probably lengthen the revenue cycle, even if they get those claims paid within 14 days of filing with the Medicare Advantage plan. You're looking at possibly 28 days as opposed to the traditional 14. So, looking at where that's going to impact us, trying to project how many patients might be affected by this, and then trying to book that in as this is revenue that's going to probably be delayed now.
Right.
So our cash flows are going to change. So yeah, I'm kind of right along the same lines as you, as where we're going to be with this, and how many hoops we're going to have to jump through to get these claims paid.
Exactly. That is definitely my concern. And Aaron, I'm sure you have some accounting concerns for the same reasons.
We do from an overall just high level point of view. I'm not as concerned for our clients about cash flow impacts, and I know that's what you were kind of talking about, but that's a piece of it. I'm more concerned about the EMR anomalies, the potential for either if we're in a revenue recognition role, I'm not as worried about it, but are we going to be able to record revenue accurately when that plan kicks in and we start seeing these double claims, duplicated claims, and how are they going to show up in the EMRs? So really more, from our standpoint, because we are in those weedy details every month, we're the ones that translate all these EMR reports into KPIs and dashboards and, statistical, reports that can marry together our, the financial reality and what's going on with your census and, trends in the industry, and then also looking at benchmarking numbers and stuff. So we're concerned about quality of data from soup to nuts, from point A to all the way through to point Z. So the quality concerns me. The likelihood of write-off is more concerning as well than a delay. Because yes, so if they're going to pay more like commercial payer sources, that's concerning, because we are going to see delays to the cash flow. But are they going to write off and or deny claims as arbitrarily as commercial payers tend to do? Just maybe to deny something just to see if there's a follow-up, because I feel like there's more of that in this sort of commercial shell game that they like to play than with Medicare, which is a little more straightforward from a billing and collections standpoint. So I'm more concerned about write-offs, because that is a hit to the P&L or to the bottom line of the agency than a cash flow delay. And the reason I'm not as concerned about it overall is just because the materiality threshold for me hasn't quite been met yet, with such a small a small percentage of the market in total. I think we're going to, and we have clients in about half of the states that are going to start that are participating. So we will start to see impacts from cash flow delays standpoint and from the write-offs. But of those two pieces, and because it's less than 10% of our overall client billings that are even going to be impacted, I'm more concerned about write-offs than I am any kinds of delays. Is it going to be harder to bill and collect, and are the EMRs going to respond to it? Because that was an issue around 2014, I think it was, when they started requiring the meds to get attached to the claims, that a lot of the EMRs just weren't ready for that change. And so are hospice EMRs keeping up with this? Are they getting their systems ready to be able to send out, like you were saying, these two primary payer source methods of billing types of or how are they get sent out, with two primaries? Is that going to be accounted for or and anticipated by the EMR companies? Because
Right.
the write-offs, that's the part, that's what hospices just can't afford a lot of. You cannot write off in this thin, slim margin service area. You cannot write off a lot of claims before you have eroded your entire profit margin for the year. So that's more concerning to me than cash flow delays, which yes, it sounds like we could move some of the Medicare claims from collection within 14 days. So basically you're about 40 to 45 days out from month end. They might move into more like a 60 days in AR average bucket. So it would be, in that sense, I will be curious to bend those two groups, the Medicare Advantage versus traditional Medicare, into days in AR, and kind of see that comparison from like an analytical standpoint. But from just a pure profit, can sustainability of the hospice program, the write-offs are the ones that's where it concerns me, because Medicare is always if you've done everything right, you're going to collect it. So to have a percentage of your claims move from relative certainty into relative obscurity is a big concern to me.
Sure. Absolutely. I agree with that as well. And I do agree that the EMR, challenge will impact billing as well as your accounting, just like you're saying. Is it going to double and book twice as much revenue? And then what will be the result? Will it actually get paid, or will it be written off? So there are a lot of questions, and we've worked really hard as a team, as a billing team, for the analysis of our clients and how these MA plans will impact those in participating states. So we're going to be well positioned to manage those claims come 1/1, and hopefully we will be able to provide you with some insight as to how the turnaround is working for us as far as payment, and also how accommodating the EMRs are. So we'll definitely follow up on that. So I think we can go to the next slide. What are the other biggest RCM challenges hospice agencies are facing in 2021? Man, I think between MA plans and COVID, I think that's enough. I don't. I think the things we've already discussed are the huge challenges. I think the increase in COVID cases again in the fall, that's predicted fall and winter, will impact agencies all the way around, from clinical staffing to billing. And then with the MA plans, that just adds another layer of complexity to billing and collections. So, Jen, what do you think you guys are facing for 2021?
Essentially, it's like what you said, it's the non-controllables. You know, our processes are clean, and that's all we have control over. It's facilities keeping their data accurate in the system, how the payers actually process claims, and those sorts of things that truly are the biggest things that I anticipate struggling with on 2021, and especially if the payer source staffing goes remote, which we didn't see. We may well see some government going remote. That I think will really impact our RCM.
Yeah, we did see some of that in some states, and I didn't bring it up before, but I'm glad you mentioned it, because we did see it, and it did definitely create some disconnect in their teams on their end, and it delayed problem claims. So if we had issues with claims processing, whether it was, and almost always a glitch on their side, they updated something and broke something else where, you know, a particular field on the claim wasn't being picked up, or whatever the case was, we were creating and submitting projects. So it would be a claim spreadsheet with claims that were denied for all the same reason, and they were inappropriately denied. And then, you know, that goes to your representative from that payer, but that representative may need clearance from 2 other people before she can process claims. And with all of those people working from home, that process was certainly delayed. And we also saw quite a lot of turnover. So we may have a project in process with someone with a particular payer, and then that person would not respond to emails, and we would dig until we found someone else, and then they would say, oh, well, that person's no longer with us. So we certainly saw payer challenges in the first round of COVID, where it really took a toll on the revenue cycle time. Just the you know, days in outstanding AR on those particular payers were certainly impacted, because we could not get claims successfully processed because their system was broken and their team was very disjointed. So hopefully we don't see that, but I can certainly imagine that there will be some of it. Aaron, is there anything else that you see as a challenge in 2021 that we haven't already covered?
Honestly, I mean, no, nothing else that I would add to this piece of the discussion.
Not like it's not enough, right?
Right.
Okay, so we can move on to the next slide. What is your agency's AR telling you about the health of your RCM process? I think for us, you know, we are the billers. We are, as Jen said, we give a lot of feedback to our clients. So when we are managing claims, we are looking at the claims in every bucket, so to speak, in the EMR. So we want to look at claims that are not ready because they have errors or missing documentation, or for whatever reason cannot be submitted. Then we look at what is ready to submit and send those claims out. But when we get claim denials or rejections back, we immediately, of course, review those and go back to the agency to gather the information needed to get those claims processed successfully. So what I think our outstanding AR usually tells us is that there's a process breakdown in-house where maybe the workflow is not flowing as it should. So there may be missing pieces of information that are essential to getting paid. Sometimes it's verification of eligibility, and the payer is not correct, or the coverage has terminated for the patient, or there is no authorization for the time period being billed. And sometimes, and I'll speak not just about our team, but I think in-house billing processes, there's always the challenge if your billing team in-house is, tasked with things other than billing. A lot of times the follow-up is the part that gets left undone. So there's not a lot of claim follow-up once the claim is submitted to the payer. And so if you're seeing a lot of balances hanging out on your AR, and in particular as Aaron said, a lot of the commercial claims or commercial payers, play the game of they deny everything once the first time to see if you'll actually follow up on it. And I think we see a lot of that. And, where our team is looking at your AR every single day, following up on claims constantly, I think in-house has a bigger challenge because when there are bodies in the office, I think a lot of times billers get tasked with things when the agency is smaller, so they wear a lot of hats. But then as the census grows and billing becomes more of a full-time workload, those other tasks are never reassigned. So it's tough to keep up with everything that may be assigned in the billing department that might not truly be billing, or maybe it's a facet of pre-bill, but it's not the actual collection part. And I think, of course, the collection part is what gets you paid. So for me, I think that those are the points that your AR can tell you about the health of your revenue cycle management. So Jen, do you have anything to add?
I just tend to look at write-offs. To Aaron's point, write-offs, unbilled revenue. I had a biller in the past who would write things off without telling us that they were writing them off, or they would not follow up timely, and we would have timely filing issues that turned into write-offs. Having a billing company, having a biller that's focused on follow-up and staying on top of things has freed up our staff to move our pre-bill process through, that we're now releasing 95% of our billing within the first 5 days of the month, whereas we were usually holding about 95% of our billing until about the 20th. So, taking that workload and shifting it over to somebody that we trust to follow up, follow through, and communicate, that is the thing that I spend the most time looking at. Aging is another, AR aging, anything over 60 days, 120 days, I start to get worried. And we're seeing those numbers go down dramatically as I put my trust into HM actually to follow up and follow through on those things for us.
Yeah, absolutely. I would echo, the write-offs obviously, but more backing up a little bit from just the, what KPIs or what like metrics do we look at about AR, because those are all, we look at the billing and billing to collections ratios, we look at the days, and we look at those by buckets. More, I think qualitative is important here as well. And from a process standpoint, if what does the agency's AR tell me about the health of their claims process? To be honest, the AR tells me a lot about the communication and the effectiveness that's going on between the clinical teams and the downstream functions. So for me, that's one of the first big red flags that I see. If they are, if they aren't on top of it, two things. So I like to see that the CEO is involved in the discussion of AR. That's always kind of a critical step, number one, because it's amazing how, that's such a critical part of the running of the business, but it's easy to just think of AR as a set it and forget it process. And it's one of the most critical areas to actually keep your finger on the pulse every month. So I like to see that the CEO is involved in that review, that they're, just like you said, Jen, that they're looking at the 120 days and over. That's the bucket that I like to tell the CEOs, always review, every month, the over 120 days. Claims that are still on your aging, that and following up with the billing team and the finance team on those claims will keep the AR healthy, leaps and bounds better than what I like to call it, just kind of a sleep at the wheel AR, where the biller is doing it and nobody's following up, because that's where it's easy to hide things, to have write-offs that never get discussed. And there should always be, a CFO and CEO agreement on write-offs, so that isn't something being done and authorized all in one place, because that's a huge internal control and big, fraud red flag as well. So those are things I like to see, because that tells me if the organization's functioning in a healthy way. And the more that isn't working, and particularly if the AR is, if we get in there, we're just seeing that it's a mess. There's a lot of negative AR amounts way out in, buckets a year or more. And then I know there's not a lot of cleanup being done, and there's a lot of AR that's also over 6 months, that if the AR doesn't look good, and when I say look good, I guess that just takes, it takes time in the industry. You can sit down, look at an aging, and know whether or not they're really staying on it. But yes, days in each bucket is really kind of the first place that I start. Then I wonder how well from soup to nut, from admissions all the way through documentation, through billing and collecting those claims, because it is more often than not an issue upstream from billing. And what I see that goes on, and what the AR tells me, if it's messy, is that the billing department is probably also QAPI slash like all cleanup of all claims department, and that's really sort of a misnomer of the billing function. The billing function should be working with the with the clinical teams to do root cause assessments and figuring out what is causing this and how do we fix it going forward. So I think the AR is one of the areas that tells me immediately if this is kind of like an agency of a tale of two cities situation with a big divide between them, or do they have a functional agency where the clinical and the finance and the billing teams are working towards a unified goal, and it, without that communication and without good good cross the lines management, it doesn't happen.
Sure. And I think just as important as looking at your AR 120 plus is looking at your unbilled or error report, because we see unbilled claims get hung up in systems and no one is actually working them unless we run the report and send it over and say, hey guys, you have to work these claims, because claims will come out of their system and they're already past timely filing before they're ever submitted to the payer, because they get forgotten in their unbilled section or in the pre-bill process, whatever that is in the EMR. And for whatever reason, it's like it just gets overlooked. So they're not looking at the payers and the breakdown of that unbilled segment of claims and managing them in an urgent way to get them out and get them processed in a timely manner so that you don't run against timely filing. And of course, there's always the opportunity for a claim to come back for any reason. As Jen said, they deny for stupid things all the time or improperly deny. So if you're running against timely filing the first time you submit your claim, you have absolutely no opportunity to correct and resubmit. And so that's a huge piece of, I believe, managing your AR is looking at the unbilled, and it does also give a great picture of everything you said, Aaron. How is that internal workflow? Is it cohesive between intake, clinical, billing, management? Is everybody on board and working toward the same goal?
Yeah, exactly. Because I used to look at the days in AR and the aging buckets and look at that as a reflection of the billing processes, earlier, and that's a component. It can be, but it's often it's often a symptom, and as is the case in many situations, the symptom is not the root cause. So when I see these issues, there's always got to be is this stemming from billing processes? Is it stemming from a lack of follow up in any one of these areas? And yeah, the point you made, unbilled is a great area for claims to just go and die, so to speak, meaning they just don't go anywhere and they can hide there. And so that's an example where the agency has to have that sort of standard set of here are the steps we take and here are the reports we run, and it should have those checks and balances in place where it's not just all in one person's pocket, so that if something gets slipped or slips through the cracks, that it isn't completely missed altogether.
Right. Absolutely. Okay, I think we can go to the next slide, and I believe that is just our closing thoughts on performance recommendations for 2021. And I feel like from our perspective, from Advanced Hospice Management, I think we've touched on the really important and the biggest challenges facing agencies, not just in 2021, but from today forward, with COVID, with the Medicare Advantage carve-in, and the components of those things like work at home, and the fact that, all of our EMR and other, online access, like we were talking about Zoom and WebEx and all of those functionalities, they really have to work, and we really have to work to make sure we smooth out those processes for us and for our team. From our perspective, it's something we do day in and day out, just like Aaron. So it hasn't been a big adjustment for us. But for a lot of agencies, I think it has been. And because we've seen some decline in COVID, and some agencies in some states, and just people in general in some states, have opened up and relaxed some of the restrictions, so people are getting back to somewhat the way they worked before. the shutdown and before people started working at home. So I think they're not necessarily anticipating that we may revert back. And I think it's important that everybody has a plan, a game plan, just as Jen said, going forward to make sure that your revenue cycle management stays intact and that all the players involved are actively participating and making sure that you have a workflow and a checklist and checks and balances, and that there are people assigned to every component of that revenue cycle management, and that those people have backup coverage in the event that they are ill or out. And like Jennifer said, Jen, I'm so sorry, that you're faced with, the other components of employment where you have clinical staff who you just can't necessarily compete in your area when there are other types of providers that are paying such higher salaries for the same staff that you need to take care of your hospice patients. So I think there's a lot of moving parts going forward, but as it all drills down to revenue cycle management, I think we have to make sure we have a solid team of people working that and a solid backup plan, and the ability to utilize all of our technology to continue to manage revenue cycle and claims and follow up so that our revenue stream is not impacted by COVID or by the Medicare Advantage or by a combination of the two. Jen,
Excellent.
do you have any?
Oh, I'm sorry, go ahead.
Oh, no, I was just going to see if Jen or Aaron had any other closing thoughts that they might want to add.
Oh, very well said. You summed it up.
I think so. I think you summed it up. And I think one of the other things too is, and with COVID happening, I was telling hospices this with carve-in happening, these are all things we have to pay attention to and look at as they happen to our industry, but just not to get distracted from the core focus of running a sustainable hospice, providing the best care that brings more patients to you, just focusing on the business, because I've seen a lot of distraction in this year as well, and not to go too long putting on the back burner, what the actual long-term strategies are, and having those important meetings and sessions with your executive team that aren't just COVID focused, because it feels like to me, for all of our hospice clients, that some of these things have dominated the conversations this year, and so just keeping that in mind and that perspective, that sometimes these things consume a lot of focus, but in the look back, when we're looking hindsight, maybe 10 years from now, these might not be as big as they seem in the immediate. They also could be complete game changers. So because we do know that, like, there's like you said, Jen, that we're going to be looking at a new normal, especially with respect to work environments and what the workforce of the future is going to look like, and expectations around that. But no, thank you, Delaine. I think that was an excellent summary wrap up.
Thank you so much.
This is Jim Parker again. I would like to thank each of our panelists for their valuable insights. We appreciate each one of you being here. We're a little over our time, so we'll have to forego the Q&A session, but we hope that you all enjoyed the presentation, and thank each of you for joining us as well. Please take care and stay safe.
All right, thank you, Jim.